This segment is on ECG and rhythms. We are not going to talk about everything, all possible rhythms. What I want to do is to help you focus on the kinds of things that are most likely to be asked on NCLEX. And so with that in mind, the first thing we're going to do is to just briefly review the electrical conduction system of the heart. So the heartbeat starts at the SA node, travels across the atria to the, that's right, the AV node. And then it travels down the bundle branches, the bundle of His, the bundle branches, and then up the Purkinje fibers, and the ventricles beat. So this is the normal electrical conduction system. The next slide I'm going to look at is not something that you probably have to know about. I mean, you probably won't see this exact slide on NCLEX. But we're going to be talking about the terms polarization, depolarization, repolarization. And so I thought I'd want us all to be at the same place as we talk about that. When we refer to the polarized state, I often think of this as the ready state. The outside of the cell is positive and the inside of the cell is negative. Then when the electrical impulse goes across the cells, the polarity changes. It flip-flops, if you will, and the inside becomes positive and the outside negative. So it depolarizes. And then after the impulse has passed through, the cell goes back to the ready state. It repolarizes. Go back to the outside being positive and the inside negative. It's almost as if the cell said, wow, that was fun. Let's get ready so we can do it all over again. Now, I don't for a minute think that the exam is going to ask you, when is the outside of the cell positive and when is it negative? They just haven't been asking that kind of questions. But you might see the terms depolarize and repolarize on the exam. Now, if we take a look at the ECG here, we know that you can measure the electrical activity of the heart. As that impulse goes through the heart, you can measure it. Now, as the impulse goes from the SA node across the atria, down here to that AV node, this is the P wave. When the atria depolarize, that's your P wave. Then, as the impulse goes across goes down through the bundle of His, through the AV node, down the bundle of His, and the bundle branches and the Purkinje fibers and the ventricles beat, that's the QRS complex. So the QRS is ventricular depolarization as that impulse is going across the ventricles. And then the T wave is when the ventricles are getting ready to do it all over again. Ventricular repolarization. So that's in essence what the ECG is all about. Now, ECG paper goes through the machine at a standard rate. And that standard rate, if we count these big boxes here, is 1, 2, 3, 4, 5 big boxes in 1 second. Suppose you had a strip that had 30 of these big boxes. So this part in here was 5. So suppose you had a long strip of paper that had 30 of those big boxes. And in those 30 big boxes on that strip, there were 7 heartbeats. 7. So what is the approximate minute rate when there were 7 heartbeats in 30 big boxes? All right, so how long a period of time is 30 big boxes? 30 divided by 5 boxes per second tells you that that's a 6-second strip. So what I told you then is there were 7 heartbeats. So 7 beats in 6 seconds. So what is the approximate minute rate? If you just told me 70, you're correct. So if there were 7 beats in 6 seconds, there would be 70 beats in 60 seconds. 6 goes into 60 seconds, 6 goes into 60 10 times. So you would have to multiply that 7 beats times 10, or a heart rate of 70. Frequently in the hospital, when we're looking at rhythm strips, you'll see a 6-second strip, because to do a full minute strip and count all the beats, that's a lot of paper. That's a long line of paper. So you'll often look at a 6-second strip. It's possible they could put that on NCLEX for you, because they sometimes do put rhythm strips on the computer for you during the exam. Now, I want to talk a little bit about some basic rhythms. Sinus rhythm means simply that the SA node is the pacemaker. The heartbeat starts at the SA node up there where it's supposed to. Now, may all your beats be normal sinus rhythm, NSR. That's what it stands for, normal sinus rhythm. We can have a sinus bradycardia, a very slow beat, a sinus tachycardia, a very rapid beat. If it starts at the SA node, it still has the word sinus in front of it. You can even have sinus dysrhythmias or sinus arrest. But if the word sinus is in front, it means it starts up there at the SA node where it's supposed to. This strip down here and these little ones on the edges here, these are all normal sinus rhythms. So these are all examples of normal sinus rhythm. You have a P wave and a QRS, a T wave, a P wave, a QRS, and a T wave. So every P wave has a QRS. Now, if you hear the term atrial in front of the word dysrhythmia, that means that the beat starts in the atria but outside the normal pathway. And we see an example over here starting in the left atrium. An occasional extra P wave is a premature atrial contraction or an ectopic atrial beat. It just means you've got a little extra impulse coming there. A whole bunch of them are atrial tachycardia, more are flutter, and even more are fibrillation. But that means that it starts outside the normal pathway. So now, if we take a look at this picture here, we see up here, you can see where you get an extra P wave in there. So you get a premature atrial contraction. Down here, you see lots and lots of P waves with occasional QRSs. So you get occasional QRSs, lots of P waves, and they look kind of sawtooth-like, and that would be considered atrial flutter. Now down here, you can't even really see or identify P waves. So you really can't identify P waves. This is atrial fibrillation. They're coming so rapidly that you cannot identify them. Now this particular patient is having a fairly rapid ventricular response to the atrial fibrillation, but notice that the ventricular beat is itself irregular. See, they are not the same intervals apart, and it's a fairly rapid, irregular ventricular beat. Now, is atrial fibrillation immediately life-threatening? No. As long as the ventricles are beating, blood, you've got cardiac output, and blood is getting out to the rest of the body. Now, people in atrial fibrillation don't feel very well. They may get all either cold and clammy or hot and sweaty. They may be dizzy and lightheaded. They may have no energy at that point, but they're not going to die immediately, because as long as the ventricles are beating, there is still a cardiac output. Now, they do have some increased risk of strokes, clots forming in that atrial chamber that is just beating like this. So there's a greater risk of strokes in people who have atrial fibrillation. Now, I want us to talk for a moment about ventricular dysrhythmias. Ventricular dysrhythmia means that the beat starts in the ventricles outside of the normal pathway. An occasional extraventricular beat is called the PVC. This means that ectopic simply means outside the normal pathway. A whole bunch of them is tachy, more flutter, or even more fibrillation. So we could have V tachy, V flutter, V fib. So let's look at a picture. What is this? That is normal sinus rhythm. If we look here, this doesn't look very normal here. What we have here are PVCs. So we have an extra ventricular beat in here that is not preceded by a P wave. So these are PVCs. What do we see here? This is a ventricular flutter. Next we have ventricular fibrillation. What's the cardiac output in ventricular fibrillation? Nothing. Nothing. Essentially nothing. So, is ventricular fibrillation immediately life-threatening? Yes. Ventricular fibrillation is immediately life-threatening. You got 4 to 6 minutes till brain death occurs. And this is when we have to do the, we have to defibrillate the patient. Another question for us. A client is admitted to the intensive care unit with nausea, moderate chest pain, and an elevated serum creatinine phosphokinase, or CPK. The client tells the nurse, quote, "My heart is skipping beats," end quote. The nurse examines the ECG and immediately identifies the rhythm as 1. Bigeminy premature atrial contractions, 2. Bigeminy premature ventricular contractions, 3. Ventricular fibrillation, or 4. Atrial fibrillation. So you look at the rhythm up at the top, and the correct answer is number 2, bigeminy premature ventricular contractions. Here's a PVC, here's a PVC, here's a PVC, here's a PVC. Every other beat, so we have a normal beat, PVC, normal beat, PVC, normal beat, PVC, normal beat, PVC. So every other beat, bi means 2. So it's bigeminy PVCs. That one was so much fun. Let's do another question. A 78-year-old male was admitted to the coronary care unit with acute pulmonary edema. He complained of fatigue, was dyspneic, and his heartbeat was irregular. After examining the above rhythm strip, the nurse documents the heartbeat as atrial fibrillation, atrial bigeminy, ventricular fibrillation, or first-degree heart block. Well, if we take a look at this, what do we see up here? Well, I don't see any P waves. I see a QRS, I see T waves, but I don't see any P waves. I also note that the ventricular beat is irregular, but it's very definitely there. So we rule out ventricular fibrillation. We can rule out atrial bigeminy because we don't see any P waves. We can rule out first-degree heart block because that has more P waves than QRSs. We can rule out first-degree heart block. With first-degree heart block, you have a prolonged PR interval, and we don't even see P waves in this one. So the correct answer here is number 1. With atrial fibrillation, there are no identifiable P waves, and I just can't see them. There are QRSs and T waves, but no identifiable P waves. And usually we said with atrial fibrillation, the ventricular beat is apt to be irregular, and that one certainly is. All right, another question for us. An elderly client with a long history of heart disease is brought to the emergency department of a local hospital following 30 minutes of chest pain unrelieved by nitroglycerin. The client's ECG has an inverted T wave. The nurse knows this finding indicates 1. First-degree heart block, 2. Second-degree heart block, 3. Atrial flutter, or 4. Myocardial ischemia. Well, the correct answer is number 4, myocardial ischemia. Now, you might know that because of the data about the inverted T wave, but don't panic. Even if you didn't know that, It says here he had 30 minutes of chest pain unrelieved by nitroglycerin. What's that? That's myocardial ischemia. So you could answer the question even if you were not an expert on rhythms. All right, another question. A client is admitted to the coronary care unit where continuous cardiac and hemodynamic monitoring is started. The cardiac monitor reveals an irregular rhythm with no identifiable P waves. The nurse knows this is 1. Second-degree heart block type 2, 2. Atrial fibrillation, 3. Premature atrial contractions, or 4. Premature ventricular contractions. And the data says there was no identifiable P waves and an irregular rhythm. The answer is number 2, atrial fibrillation. We've looked at ECGs and questions about ECGs in a number of ways. Some of the questions you had to interpret a rhythm strip. Some of them you were given verbal things, verbal descriptions of a rhythm strip, or even names or labels of it. So what I've tried to do is give you questions in a number of different ways that I think it's possible that the questions could be asked on NCLEX. Now let's do another question. The nurse observes the following dysrhythmias on the monitors. Which client should be attended to first? The client who has atrial fibrillation, first-degree heart block, 2 premature ventricular contractions in a row, or ventricular fibrillation. And the answer to this question is, of course, answer number 4. We discussed a few minutes ago that ventricular fibrillation is immediately life-threatening. You have 4 to 6 minutes until brain death occurs. Now I thought we would talk a little bit about heart block. When we talk about heart block, the patient has difficulty getting the impulse from the SA node through the AV node. So it's the AV node that has the problem. So it's slow getting through that AV node. If the patient has first-degree heart block, it simply means the impulse is slow to get through the AV node. If it is second-degree heart block, some impulses get through and some do not. So this patient would have more P waves than QRSs. And if it's third-degree heart block, none of the impulses get through the AV node. So that means that the atria and the ventricles are beating independently of each other. So the atria are beating and then the ventricles beat whenever they feel like it. So the atria beat right along and then the ventricles go in sometimes at the same time in no relationship. So the cardiac output in someone that is in third-degree heart block is really, really poor. These people faint a lot. Sometimes your second-degree heart block patients faint. First degree probably don't even know they have the issue. Let's look at some rhythms. First, we see a normal sinus rhythm for a reference point for us. Then if we take a look at this with first-degree heart block, what we see here is a prolonged PR interval. So here's a P wave and here's the QRS. It's a longer than normal time period. Compare that to the one up there. So we have P wave a long time before the QRS. So what we have here is a prolonged PR interval, and this is first-degree heart block. The impulse is having a hard time getting through that AV node. Now the next thing that we see here, if we look at this one, we have a P wave and no QRS. And then another P wave and a QRS. So this means that every other P wave gives us, is followed by a QRS or a ventricular beat. So if, for instance, if lub is the atria beat and dub is a ventricular beat, this one goes lub, lub, dub. Lub, lub, dub. So every other atrial beat is followed by a ventricular beat. Now, if we take a look at this one, what we see down here is a complete heart block. You note the P waves are identified here, and they come anytime they feel like it. And there are occasional QRSs here in no relationship to the P waves. So, and now this is like, sometimes they say it's like a dysfunctional family. The atria and the ventricles aren't talking to each other. If you look at this strip, sometimes the P wave may follow right on top of a QRS. These people don't have much cardiac output, and they faint a lot. These folks are great candidates for pacemakers. The next thing we're going to talk about is indeed pacemakers. And while we have been talking about heart block, this is certainly one indication for a pacemaker. It is not the only reason for a pacemaker. We're not going to go into all the possible reasons for pacemaker. It's a common one, but not the only indication for a pacemaker. Now, if a patient has a pacemaker, they have a battery-like device that's placed somewhere in the chest wall area. And then there are leads or electrodes that will go to the heart and stimulate the heart to beat. There's some nursing care that's relevant to that. We teach the patient to check their heart rate daily. This is just for an idea to make sure that the heartbeat is still regular and in the rate at which it should be. We encourage patients frequently to avoid sources of electricity. Now, this is one I have a hard time with because every generation of pacemakers is better than the one before it. And some pacemakers are so well insulated that the microwaves are not a serious threat to them. However, I still think it would be a good idea in terms of exam questions. If you had an exam question about a patient who has a pacemaker, probably wouldn't encourage them to do all their cooking in a microwave. We might also want to warn them about putting cell phones in, say, breast pockets. Men will sometimes put a cell phone right up here. Not a really good idea. Some patients have had cell phone interference with their pacemakers. In fact, if you read the instructions on a cell phone and you read every page of it, somewhere on the next to last page it says that you should keep that cell phone. Usually it says something like 6 inches, 5 or 6 inches from any pacemaker. Sometimes even things like garage door openers have caused difficulties with pacemakers for some patients. So again, you might have a patient where the doctor says this is not an issue, but it's very possible to be an issue. Another thing that's been issues for patients has been when they leave stores that have, where they're, particularly clothing items, but other kinds of items have those little magnetic things on them that they have to manually remove. And so if you go through the little stanchions at the exit door, it will beep if you are carrying stolen merchandise. Well, sometimes these kinds of devices have indeed set off the pacemakers, so that patients with pacemakers may have difficulty going out through that kind of a security system. So that's another possibility of a problem with pacemakers. Not all patients may have it. It depends a bit upon the variety of pacemaker. We also usually tell patients with pacemakers that we don't want them to engage in contact sports, but that's not usually a big issue for most patients. I thought we'd take a look at a couple of different types of pacemakers. We can have atrial pacing, where you see the lead wire goes into the atria. And what it does is it gives the atrium a little bit of a shock and tells the atria when to beat. Probably the most common type of pacemaker is a ventricular pacemaker, and you see the lead wire is down in the ventricles and tells the ventricles to beat. So it gives it a little zap, zap, and tells the ventricles to beat. Now, some people have AV pacemaking, so that there's a little electrical zap for the atria and a little electrical zap for the ventricles. So they may have two zap, zap with that. Some pacemakers beat continuously at a given rate. Those are called fixed rate pacemakers. Some pacemakers are demand, so that when the patient's heartbeat goes below a preset level, then the pacemaker kicks in and starts to beat. So you'll see a variety of variations with pacemakers. Now, I thought we'd take a look at a strip here that relates to it. When the pacemaker goes zap, there's a little electrical current that is a vertical strip, so a vertical line. So you can see a little line there. You can see a little line here, here, here. What those are, that this would be a ventricular pacemaker, and you can see that that line or spike that represents the electrical activity of the pacemaker is before the QRS. So if the patient had a ventricular pacemaker, the spike on the ECG would be before the QRS. If they had an atrial pacemaker, the spike would be before the P wave. And if they had an AV pacemaker, you'd have two spikes, one before the P wave and one before the QRS complex. I think sometimes NCLEX has asked a question about the spike, indicating that the pacemaker is functioning effectively. We need to take a look at the management of fibrillation. When we were talking about the rhythms a few moments ago, you told me that ventricular fibrillation was immediately life-threatening and atrial fibrillation was not. So with ventricular fibrillation, it is indeed an emergency, and the treatment is defibrillation or shocking. With atrial fibrillation, if medications such as digoxin and other antiarrhythmics don't work, then the patient may undergo a cardioversion. Not everyone with atrial fibrillation will be cardioverted, but some will be. Now there's differences and similarities between defibrillation and cardioversion. They both use an electric shock. The big difference is that defibrillation for ventricular fibrillation is an emergency procedure, so you don't get the patient's permission to do it. You don't have them sign a release form, and they're not prepared. When their heart stops beating, if they're in VFib, unless there's a patient with a do not resuscitate order, that patient is likely to get a shock. And so if the patient gets the defibrillation or the shock, the hope would be that it would stop the heart and then it would restart in normal sinus rhythm. If it does, fantastic, you've just saved that patient's life. Suppose it does not, then what would be done? Crank up the power and do it again. And how many times can we shock the patient? That's right, up to 3 times we'll probably shock the patient. If at the end of 3 times there is no return to a rhythm, then the patient has gone already. Now, if you were in the middle of a code and the person with the paddles says, clear, what do? Take your hands off from the patient, stand away from the bed, because that means the electric shock is about to be administered. The button is about to be pushed. And you really don't want to get that electric shock too. Okay. Now, with atrial fibrillation and the cardioversion procedure, this is a planned procedure. The patient is usually kept MPO after midnight. They sign a permission form. This patient is prepared for the procedure. They're going to be put to sleep during the procedure. And the hope again is that it will stop the heartbeat and restart in a normal sinus rhythm. When cardioversion is being done, it's very important that the machine be in the synchronized mode, because if that shock happens to hit the T wave, then that could put them from atrial fibrillation to ventricular fibrillation, which is even worse. So we wouldn't want to do that. Now the next picture I have for you shows a person here who was in atrial fibrillation. The shock is applied, the heartbeat stops, and then it restarts in a sinus rhythm here, a normal sinus rhythm. And that's the hope of what would happen in the cardioversion. All right, now I also want us to talk about one more thing in this section. I want us to talk about CPR. And I have a hard time talking about that because, as you probably are very well aware, the protocols keep changing on CPR. Sometimes it seems as though it's almost on a monthly basis that the protocols change, although that may be a little bit of an exaggeration. So I thought we would come down to kind of what I think is the safe thing to talk about with CPR. Now do remember, though, that on areas of controversy where there's flux and controversy, NCLEX usually pulls the questions on that. So don't get terribly worried about it if there's just been a real recent change in a protocol for CPR. Now the first thing you need to do is check for responsiveness. So you see somebody and they don't look right there. They're laying there. You check for responsiveness. If there is no response, we really should call 911 if you're outside the hospital environment, for instance, because you want to get help coming as quickly as possible. You need to tilt the head back and listen for breathing. If there's no breathing, you can pinch the nose and cover the mouth and blow until the chest rises. Give 2 breaths, about a second each. And then you can give 30 chest compressions at the rate of 100 per minute. Now this is for an adult. So 30 chest compressions. And that's a fairly rapid rate. So you're giving 30, but the rate would be about 100 per minute. So that's not quite 2 per second, but it's a fairly rapid rate of chest compressions. What research has shown us is that the biggest benefit, once the airway has been established and you know there's an open airway, the biggest benefit of CPR is the chest compressions because that circulates the blood. So there's been a bigger emphasis on more chest compressions and less of the breathing of the breaths. But essentially, we're at a 30-2 rate in most of the protocols at the moment. But these do change on a very frequent basis. Let's do a question. The nurse finds an adult lying on the floor unresponsive. What is the most appropriate initial response for the nurse to take? 1. Immediately start CPR. 2. Notify the physician. 3. Check respirations and pulse. Or 4. Put the client back in bed. So the client is unresponsive. The most appropriate initial action is number 3, check respirations and pulse. See if there's a problem here. If the patient is simply sleeping or drunk, you don't want to immediately start CPR on the patient. Another question. The nurse is administering CPR to an adult man. What initial nursing assessment best indicates the client has been resuscitated? 1. He is awake, alert, and conversing. 2. He reports he is free of chest pain. 3. He has a palpable carotid pulse. Or 4. He has a regular heartbeat. And the one that best indicates he's been resuscitated is indeed number 3. He has a palpable carotid pulse. Very few patients recover from having had their heart stop beating, and so they don't wake up from having had CPR administered to them saying, "Thank you very much, thank you for saving my life." That only happens in the movies and on TV. But you should have a palpable pulse. May or may not be regular, but you should have a palpable pulse.